Hello, welcome to my presentation of my master's thesis. My name is Robin Scharnagl. I'm a master's student in biological and clinical psychology at the University of Regensburg, and I'm currently writing my master's thesis at the Center for Neuromodulation and the TMS Lab in Regensburg. The topic of my work is the Personalized Advantage Index for predicting treatment success in tinnitus, a retrospective analysis of Unity data. Tinnitus is a highly heterogeneous syndrome with inter-individual differences in etiology, pathophysiology, characteristics of tinnitus like loudness or the ability of masking, comorbidities like depression, anxiety, or insomnia, and this leads to a highly heterogeneous response to treatment, so not all patients do benefit equally from the treatments. For most of the treatments, quality of evidence is poor and highly variable due to this heterogeneity of patients. But the problem is that guideline recommendations and therapies often do not take into account the inter-individual variations, so the heterogeneity of the patients. So there is a need to personalize tinnitus treatment by considering patients' individual characteristics and to identify biomarkers that can predict treatment success. Previous literature already found several predictors, such as clinical or demographic variables, for example, tinnitus-related distress, audiometric characteristics, or demographic variables like age and gender that were found to be predictive of treatment success. But the results remain inconsistent, and till today there is no established algorithm how to personalize tinnitus treatment. So our research question was, can we predict the treatment outcomes for patients undergoing a tinnitus treatment by using clinical and audiological variables? Therefore, we used the Personalized Advantage Index, short PAI, that was first introduced by de Rubeis et al. 2014. The PAI is an index that shows the predicted advantage of one treatment over another by calculating the difference between the factual prediction, that is, the predicted outcome of the actual received treatment, and the counterfactual prediction, that is, the predicted outcome of the treatment the participant did not receive. The predictions are based on a machine learning algorithm according to the advanced approach by Manke et al. To reduce data leakage. For our analysis, we used data from the Unity RCT that was conducted between 2021 and 2023. Patients were randomized to one of 10 treatment arms, consisting of 4 single treatments and 6 combination treatments. For the training of our model, we only included patients that received a single treatment. That were in total 230 participants. The 4 treatments were hearing aids, sound therapy that was delivered via app, structure counseling that was also delivered via app, and CBT. Before and during the study, the participants had to fill out questionnaires, for example, tinnitus-related questionnaires or personality questionnaires, and audiological measurements were conducted. These variables we used as possible predictors for our model. The outcome variable was the tinnitus-related impairment, which was measured with the Tinnitus Handicap Inventory, the THI. Here we see the main steps of our analysis. We first made a feature selection based on a systematic literature research. We wanted to search for variables that were found to be predictive of treatment success in previous literature, in either one of the treatments that were also used in the Unity RCT. After this, we conducted a 100 times 5-fold cross-validation. In the box, we see one iteration of the cross-validation. We first split up the data into a training fold and a test fold. The training fold included 80% of the data, the test fold 20%. Within the training fold, we first imputed missing data with multiple imputation by chained equations. We did this separately per treatment, so we had one model per treatment. Then we conducted a feature selection with an elastic net regression. After this, with the selected features from the elastic net, we trained one model per treatment via ridge regression. That was our final model. With the final model, we then made for each participant the post-treatment predictions for all treatments. So every participant at the end got 4 predictions, 1 prediction for each treatment. So also for the treatments the participant did not receive. So that are the counterfactual predictions we need to calculate the pi. Within the test fold, we evaluated the model performance also separately per treatment. Post hoc, we calculated the pi. The pi is actually used for comparing 2 treatments. In our analysis, we had 4 treatments. So we made 2 comparisons. In our first comparison, we compared the optimal treatment, that is, the treatment that led to the lowest post-treatment prediction for a participant, and compared it with the second optimal treatment. And the other comparison was the optimal treatment compared with the least optimal treatment. Let's look at our first results. Here we see the performance of the machine learning models. We see the mean squared error, the root mean squared error, and the R squared. When we look at the R squared, we see that the explained variance is between 28 and 38% for the treatment models hearing aids, sound therapy, and structure counseling. For the CBT model, however, the performance and especially the explained variance is much lower. The reasons that could explain it, I will come to this later. The next step in our analysis is then an external validation of our models with the 231 patients from the combination treatments of the Unity RCT to see how good our models generalize to new unseen data, and also to see if there are differences between the treatment models. Then let's look at the results for the personalized advantage index. In the table, we see the means and standard deviations over all participants, folds, and repetitions. In the first line, we see a mean pi of 5.30 for the comparison between optimal and second optimal treatment. This means that when a participant gets its optimal treatment, according to the machine learning model, the predicted outcome is at mean 5.30 points lower in the tinnitus handicap inventory compared to when the participant would get its second optimal treatment. When we look at the comparison between optimal and least optimal treatment in the second line, the advantage for the optimal treatment is even bigger, namely 15.95 points in the THI. When we then look at the minimal clinically important difference, using the thresholds 7 and 11 for the THI, we see that for the threshold 11, for 83.9 participants, and when using the threshold 7, even for 100% of the participants, a clinically significant advantage is predicted for the optimal treatment compared to the least optimal treatment. The next step, we conducted an internal validation of our model. Here, we did not look at the predicted outcomes from our machine learning models, but at the actual outcomes from the Unity RCT. And we compared them between participants that were randomized to their optimal treatment and participants that were randomized to one of their non-optimal treatments. Therefore, we made a 2x2 mixed ANOVA with the THI score as the dependent variable. The ANOVA yielded a significant interaction effect between the within subject factor measurement, that are the measurements before and after treatment, and the between subjects factor received optimal, so that are the groups, so the participants that received the optimal treatment and the participants that received the non-optimal treatment. In the figure and in the post-hoc tests, we can see that the symptom improvement throughout treatment was stronger for the participants that received their optimal treatment compared to those participants that received one of the non-optimal treatments. The post-hoc tests show that for both groups, the improvement throughout treatment was significant. But the improvement for the optimal group was bigger. At mean, it was 16.30 points in the THI, whereas in the non-optimal group, the improvement was at mean 6.40 points in the THI. And only in the optimal group, the improvement was also clinically significant. So what do the results tell us? We can say that the personalized advantage index based on predictions of a machine learning algorithm is an appropriate and efficient measure to predict the advantage for a treatment compared to other treatments for individual patients. We saw that only 29.6% of the participants in the Unity study were randomly assigned to their optimal treatment. So around 70% of the patients did not receive their optimal treatment. So in future, if we use such an algorithm in clinical practice, a lot of patients could benefit from it and get the treatment they actually need. So such an algorithm could help to personalize tinnitus treatment in clinical practice. A limitation of our study is the weak performance of the machine learning model for the CBT. We saw that the predictions were highly variable between the folds and repetitions of our cross-validation. So that could mean that the predictors for the CBT were not sufficient enough to produce stable predictions. So we can say it can be difficult to predict treatment outcome for specific therapies. And these results can partially also be explained by the small sample size of 56 to 59 participants per model. So in total we had 230 participants, but we had to split up to 4 treatments, so we had to split up the sample by 4. The next step in our analysis is then the external validation of our models with the new data from the combination treatments. And future research should also use this algorithm with other tinnitus treatments. So to see if this algorithm also works with other tinnitus treatments like TMS, neurofeedback, or medication. So, thank you for your attention and for the opportunity to present my master's thesis at the TRI Academy. If you have any questions or feedback, please feel free to drop them in the comments below or contact me directly via email. Here you find my literature. Thank you for watching and have a great day.